Hi, everybody. Welcome back to the living room. Thank you all for coming tonight, and thank you everyone online who signed in to watch. We have a really exciting program planned for you tonight. As you are all well aware by the many emails you've been getting from Michelle, Dr. Carbone is here from OSU to talk to us tonight about the art of treating lung cancer, along with the science. So we're really, really excited to have him. There's a lot of new faces in the room tonight, so we do have a sort of a heavy planned conversation. So I do want to do the around the room, particularly for some of the new faces that I see, but also to give Dr. Carbone sort of an idea of his audience and who he's talking to. So sadly, there's new people to my right and my left, and I'm certain that they're probably not going to want to start. Elizabeth, would you mind starting? But I do want to keep it brief, so I know
with a mouthful of
just sort of your name, when you were diagnosed, and what you were diagnosed with, so that way we have enough time to engage in some robust conversation.
Certainly. My name's Elizabeth Lacassi. I was diagnosed in 2006. I had a lower left lobe removed and then a wedge resection. A year later, started on a chemotherapy and progressed on that. Had molecular testing done at that time, was considered wild type. Changed to UC Davis, and because Dr. Gandara suggested doing molecular testing at that time, was the wild type. Went on a clinical trial up there of Alimta and Tarceva. Have been on that for a total of 80 cycles, which represents about 4.5 years, which was absolutely phenomenal. I have, by the way, I have bronchioalveolar carcinoma. About 6 months ago, I progressed, but before that time, I had a second round of genomic testing done through Foundation Health, and found out that I was ROS1, had the ROS1 mutation. And about 8 weeks ago, I went on crizotinib, and 3 weeks ago found out that I am in complete remission, and Dr. Gandara's kicked me out to 3 months till my next appointment. That's how confident he is with my response. So I'm just on absolute cloud nine for obvious reasons.
Yay.
My name is Tina, and I was diagnosed 4 years ago at stage 3B adenocarcinoma. And I had a scan last week, and everything's good. And I'm on Tarceva, yes, for 3 years.
Actually, the doctor said it was beautiful.
And so is Tina.
Hello, my name is Rosemary, and I was diagnosed about 15 months ago with adenocarcinoma. And right now I'm taking afatinib. I was diagnosed with a HER2 mutation, and everything looks stable for the time being.
They have one, Rosemary. Yeah.
Wait.
Hi, I'm Nancy Capelli, and I think a lot of people know my story in here, but it's probably worth a little bit extra since Dr. Carbone's here. But my mom went to see Dr. Carbone. She's in Alabama when he was at Vanderbilt, as a second opinion to what they thought was metastasized breast cancer. He examined it and did the genetic testing and found it was T790M, and said, your children should be tested. This is inherited. And so 2 years ago, almost exactly, I went to Stanford and got tested. They, at the time didn't even know what I was talking about. And I said, well, you need to do it. And they had to send it to Vanderbilt at that time and have my blood tested. And sure enough, I had it. And they, they didn't know really how to deal with it. So baseline scan. And they did the baseline scan, and I had some nodules, which was kind of frightening, but it was very, very early. They took the biggest, there was one that was bigger and kind of more compact, and I had the wedge resection done on that, and it was stage 0. So I was very lucky and thankful, and so happy to meet Dr. Carbone in person.
So now that I have supper, okay. Weighed myself at the gym today. I saw a number I hadn't seen since I was 11 years old. It wasn't a good sign, so they keep telling me to keep eating. Most of the time I don't feel like it. But 3.5 years ago, so I got diagnosed, an elite athlete who never thought he'd get lung cancer. The only other ones were going to be ovarian or breast. I didn't think I was a candidate for those. So when they told me lung cancer, I said, "You got to be kidding." I said, "Nope, I'm not kidding." So early on, was fortunate living around here, got tested, and found out I had the EGFR mutation. So went on Tarceva, had 13 incredible months with a response that was almost unprecedented from what I'm told by my friends at Genentech. It was like giving me speed. I'd like to be on it again right now. It'd be great. But all good things must end. Went to IV chemo for about 6 months. That was terrible. Then decided that I wanted to participate in a clinical trial. And two of my friends are back there from the company Clovis, that are doing the clinical trial of a medication, which is making very good progress. So I thank them all the time for their work. And I spent all of 2013 on that trial. But again, all good things must end, and I progressed enough. So we decided that we would go to afatinib and cetuximab. And I've done that for about the last 7 or 8 months. And that went pretty well for the most part, but I started to progress. So then I had the wonderful opportunity to find out about what some of you I've heard talk about for the last couple of years. So I got a triple-headed cocktail of Taxol, Avastin, and carboplatin. And the first couple of days was great. Day 3, I have never had that kind of fatigue. And it felt like not only did I have the fatigue, but I'd been in the ring and I lost big time to somebody who could really punch. So it took 7 or 8 days to kind of bounce off the bottom, come back up, get back to the gym, keep working out, do my stuff. So I'm in the sweet spot right now. I have until next Monday to find out if the second round is better, worse, or at least I'll know what's going on and go forward with that. In the meantime, I assiduously am looking for and talking with my doctors about the PDL1 trials, both from MedImmune and Genentech, which I'm very interested in because I'm convinced that my own immune system has to fight my own cancer. And I've thought that for 3.5 years. The trials are ongoing, so I expect shortly to be part of one of those, and then we'll see what happens. But that's only plan E or F. I still have a lot of other letters left in the alphabet, and I learn a lot from all of you here about what you're doing, what's going on with you. So we'll see what happens. But I'm feeling good today. That's what counts.
That's good, Neil.
Hi, my name's Doug, and I was diagnosed on July 9th of this year with stage 4 adenocarcinoma. And I started almost right away on Tarceva. And last Thursday I had a PET and CT, and the PET did not illuminate at all. And the CT showed that the tumors are stable. So I'm riding the Tarceva wave, I like to tell people. And I hope it's a long one like some of the folks in the room here.
Awesome.
My name is Ernie Schmidt, and I've actually spent the entire day here learning about the foundation. I'm actually taking a class on strategic philanthropy to learn more about it. The class is going to be giving some money away, and I have given to this foundation before, but like many people, we give, but we really don't know what either we're giving to or we give just to support that individual. And a couple of months ago, I had a friend who was a patient here who passed away from lung cancer. So made a decision to just learn more about the foundation.
Hi, I'm Corey. A little on the younger side here, but I feel at home with you guys. I was diagnosed in May this past year with stage 4 adenocarcinoma. Right away did testing for molecular testing and am ROS1 positive. So started Xalkori in about mid-July, had my first PET CT scan last week, And the nodules in the lung are already gone. The lymph nodes are clear. And so now we're just watching the bone mets, and they said they're shrinking. So I'm pleased.
So you're riding the crizotinib wave.
Hi, I'm Sally, and I was at high risk, so I joined the International Early Lung Cancer Study, and after 5 years, found out I had lung cancer. But because of that, I was found very early. I had stage 1 adenocarcinoma, and after my lower right lobe was removed, thus far, even though I have a lot of other nodules, nothing's grown, and I'm stable and glad to be here.
You don't have to.
Hi, I'm Martin. I went to high school with Sally, and I'm so excited. Sally was the first person we called when my wife was diagnosed a couple months ago. So we're in the beginning stages of taking Xalcori.
Awesome.
Go back over to this side. Does anybody in the back? Joan, I saw you sneak in. Ben, Jim, anybody? You don't have to. It's up to you. Do you want to introduce yourself?
Will it reach? Don't strangle anybody, Danny.
I'm Joan. This is my husband, Ron. I've been diagnosed with lung cancer, stage 4 lung cancer for this is 1 year, my almost 1 year anniversary. I've been on Tarceva. I have the EGFR mutation, and that has worked well. Tarceva has worked well for 7 months, and now I'm on the Novartis clinical trial. It's INC 280. I'm taking 400 milligrams, testing the dosage toxicity on this clinical trial. To address c-Met overexpression. And so I'm in the second month of this clinical trial, and I'm hoping it works well. Do you have any chance to add?
I'm her driver.
Kazel just passed the mic, but she happens to be Mrs. David Carbone.
Hi, my name's Betty Corner, and I was diagnosed about a month ago with adenocarcinoma. I was ready to have my right lower lobe removed, and they found a couple brain mets, and so now we're on hold. And after one round of chemo, we found that I am EGFR positive, and so I will be starting Tarceva in a couple of weeks. And I have no idea what most of you people are talking about, so I'm here.
That's a good thing.
Hi, I'm Amy Anselmo. I'm with Myriad Genetics in their lung division, which is a very new division for them. And we have a newer test that's looking at early stage adenocarcinoma only. We're basically testing for the aggressiveness of the tumor versus the EGFR and dilating that way through DNA. So we're looking at RNA and the expression of those cells, seeing how aggressive those early stage tumors are.
My name is Hope, and I have a business called Hope Assistance, and I work with cancer patients as a personal assistant, just have like a family member for hire. And I come to these meetings because I learn a lot of valuable information for my clients so that I can help them.
Jim? No. Fred? Anybody on the wall? No? Do you want to? No?
I'm Chris Harrison, and I was diagnosed early in February of this year with adenocarcinoma, stage 4, and went on one of the standard protocols, I guess, with carboplatin and Limta and Avastin. And initially, my tumor shrunk, and then I had a CAT scan about 2 weeks ago, and my tumor's back, the main tumor. And so, thanks to all the great advice I've gotten here and other places. I already had Plan B in place. I have switched doctors. I've switched to UC Davis Medical Center. I went to see Dr. I just went blank. Gandera, sorry, chemo brain. I went to see Dr. Gandera. He got me in immediately last Wednesday, and he said we need another biopsy. He doesn't think my first biopsy was even accurate, let alone, and we already knew there was insufficient tissue. So we did that was last Wednesday I saw him. We did the biopsy yesterday morning in Sacramento, and in 3 weeks, I'll know a whole lot more, but I am so thrilled to be on this new path and so optimistic. Thanks. I hope, like you, to be driving to Sacramento every 3 weeks for the next 5 years.
There you go.
5 years, Mike. 5 years.
Hi, my name's Rebecca. I was diagnosed 2 years ago this month. On Halloween 2 years ago, I had my left lung removed. They couldn't stage me right because my tumor was so big. But so between stage 2 and stage 3+, and I had a doctor's appointment this morning that was supposed to be my 2-year all's well doctor's appointment, and they saw a couple spots on my CT scan. So I have a PET scan and MRI on Friday, and then we'll know more from there.
Hi, I'm Henry Herringsma. I'm a scientist with Clovis Oncology working on our 3rd-generation EGFR inhibitor.
Jason Litton, an oncologist with Clovis Oncology, working on the same program.
Do you guys want to do that? Go ahead.
Sure. Sandy?
Hi. Sorry, my voice is affected by the chemo. So, my name is Sandy, and at the end of August, I was diagnosed with stage 4 adenocarcinoma. I'm currently on a regimen, just ending the 3rd cycle of cisplatin, Alimta, and Alastin. The CT scan at the end of the 2nd was very positive. There was a pretty significant reduction, but I still need to get the molecular testing. I'm in the process of that, and very much thinking, especially after the last 5 minutes, that we need to probably look past the current physicians that we have. And I am in the process of trying to make an appointment with Dr. Gandera.
We can help.
So, perfect. That's where I'm at.
I'm Esty Caldwell, and I was diagnosed in 2003 with blanco alveola, and I had my top lobe on the right side taken out, and the center lobe, because it was attached to the top and it was too small. They said they couldn't separate it, and so I didn't have to have chemo or anything. They told me. And so it's been 11 years, and yes, and I do have spots, nodules and so on. Anyway, they're just monitoring it once a year at Stanford. Okay, thank you.
So Esty wins the prize for 11 years cancer-free.
Actually, it's more than 11 years.
Is it more than 11?
Well, it was February of 2003 or March of 2003, I'm trying to think. So it would be, 11 years.
Okay.
Yeah, 11 and a half.
And we have another member of our group. His name is Wells Whitney, and he is 14 years cancer-free of stage 4 lung cancer. So, our goal is hope here. So.
Yes. Hi, I'm Christine Ott, and I'm here for my mom, Noreen, who's watching from Sacramento on the internet. And she's 74 years old, was diagnosed in the end of February with stage 4 non-small cell lung cancer, adenocarcinoma. She was biopsied and determined through Foundation Medicine test to have the EGFR mutation plus L858R. She started Tarceva in the end of March and was on that through her first PET scan, looked like she had a partial remission. And then at the second PET scan showed some disease progression in several bone metastases. So they were trying to determine whether they could get a safe tissue specimen from the bones and a viable specimen. They were able to do that on September 22nd, and the test this time was sent to Response Genetics to determine what the next course of therapy might be, to determine if she had the T790M mutation. And the Response Genetics test came back. It was a weak signal, so now they're sending the test on to Clovis Pharmaceuticals to their central lab to confirm if she might be eligible to enroll in that clinical trial. So we are waiting to hear back from that, and she's being treated by Dr. Reese at UC Davis. Thank you.
Athena, I saw you sneak in. Do you want to introduce?
Yes, I have lung cancer, and it's stage 4, and I've been on Tarceva now for 2 years, and I'm doing well. The only real bad side effect I have is this really bad rash on my head. It almost feels like a burn. But I've tried so many things, and Campho-Phenique seems to really work well for me. So, and then I have a new oncologist that I'm so excited about, Dr. Lopez Kaiser in San Francisco.
I love him. Yeah,
I know,
good
he's
guy.
so good.
Yeah.
I'm so glad to have him.
Yeah, good guy. Okay, nice. Okay.
Anybody else? Arash, I know you moved over in the corner.
Arash.
Are you good over there? Do you want to introduce?
You want to introduce yourself? Where are you?
He's standing. He's hiding over by Tony.
Oh.
He's saying no.
I won't take the time. I already introduced myself.
Yeah.
Okay.
Leave him alone.
Okay. Okay.
Okay, so with that, I just didn't know if somebody was walking in. Thank you all for sharing your stories and keeping them brief. I know sometimes that's hard, and I like it. I like it when we have more time to share our stories with one another. But I feel like tonight's topic is so important. I wanted to jump right in, so thank you very much for keeping it short. So with that, I want to introduce Dr. Carbone, and I know that you guys all have the hard copies of all the emails that you received with a little bio on Dr. Carbone, but I want to read it for some of the people online who maybe, like me, don't necessarily read everything that comes in one of their emails, because I think it's important. So Dr. Carbone is an expert in the molecular genetics of lung tumors, which includes understanding specific cells and genetic markers in each patient's lung cancer and developing treatments and drugs that target specific tumor cells. His research interests, grant support, and publications focus on lung cancer, specifically genetics, immunotherapy, tumor-associated immunosuppression mechanisms, and gene therapy, which is like a huge mouthful, right? Among many leadership roles, and this is one of the things we're very excited about for Dr. Carbone, is that he's the current president-elect for the International Association for the Study of Lung Cancer. And I know you guys hear us talking all the time about things we've learned when we've come back from these meetings and some of the hope on the horizon, you know, and some of the things that we're talking about. So we're really excited for him in that. He's also the chair on the Scientific Leadership Board for Alchemy.
And what is alchemy?
You guys, well, for some, yeah, that is sort of a big question. We could have a whole living room on it. But for those of you who don't know, Alchemy is the Addario Lung Cancer Medical Institute, which is a sister organization to the Addario Lung Cancer Foundation. It's a contractual consortium between academic centers and community centers. We run our own studies. Nancy talked a little bit about one of the studies we run through it, which is Inherit, looking at the T790M mutation as a possible germline mutation, as opposed to what was previously thought to be an acquired resistance. Our second study that we just launched, the genomics of young lung, which several of you in the room and watching online are actually participating in. So thank you for that. So
And Dr. Carbone is the chair of our leadership board.
Yes, and I'm excited to kind of say this sentence because I'm going to fumble over the word because, well, I'll say it and you'll know. So in 2009, Dr. Carbone was the recipient of the BJALCF's Asclepius, is that how you say it?
Asclepius.
It's terrible, right? Award, presented annually by Dr. Jablons, who some of you have heard us talk about. He's actually been in here and spoken at the living room. So David Jablons gets to pick who receives that, and in 2009, he picked Dr. Carbone.
It's a peer that chooses.
Yeah.
So that's
and Asclepios was the Greek god of medicine and healing, which absolutely defines who Dr. Carbone is. So with that, we're going to break right into what we're talking about today. So I think I want to start the conversation when we talk about the art of treating lung cancer versus the science. What do we mean? First of all, can we start there?
it's a long discussion, but if we knew everything about cancer and we knew everything about medicine, we could boil it down to a computer program. But the sad fact is we don't know everything about cancer or how to manage it. And as people have said in the room, they've had sent off one test and it was negative, and then somebody decided to send off another test and they found a ROS1 mutation, or they found a T790M. And so I think it's very important to keep in mind that managing lung cancer is not like a factory job, that every patient is different, and you have to listen to the patient, you have to be experienced in managing the disease, and keep thinking about things that you might have overlooked, or you might try, go to meetings and hear about the latest therapies, and try things that show a glimmer of hope in a small number of patients potentially at some other, maybe in another country that's tried this. Because the people who are dealing with lung cancer right now, they have to have solutions now, not after the phase 3 trials are done, not in 5 years when the drug gets approved. And so I think it's very important to push limits when it comes to finding the right things for every patient. And it's especially problematic now as insurance companies are becoming more prescriptive. If you don't follow X guideline, you can't do it. And it makes it much more difficult for us to try to tailor things to patients.
So let's take sort of the art of treating into a specific topic and revolve it around targeted therapies. So whether it's oligometastatic disease or limited progression, how might a patient, because we talk to patients here all the time, right, who they're on a targeted therapy, be it a Tarceva or Xalkori, and the smallest little progression, and all of a sudden their doctor's changing their entire therapy regimen.
Right. So if you read the textbooks on lung cancer, stage 4 disease is not treated by surgery, for example. And on the other hand, I have many cases of patients who have 1 or 2 brain metastases and a lung lesion, who can have the lung lesion taken out and the brain metastases treated, and that's by definition stage 4 disease, what we call oligometastatic disease. And many of these patients are cured of their cancers if you treat that aggressively and not according to the textbook. And this is especially true with things like targeted therapies, EGFR targeted therapies. I had a patient that had 20 spots of cancer that we could see on scans, EGFR mutation, responded very well to Tarceva for a couple of years, and then of those 20, 1 spot started to grow. And the classical way to manage that is to stop the Tarceva and try chemotherapy. But I thought that this drug was clearly holding the other 19 spots. This one was readily removed, so we took it out surgically. And she went for another several years and had another spot that grew. We took that one out. And she went for more than 10 years before she died of something else. So in essence, we had cured her lung cancer. She never saw chemotherapy, and she was completely asymptomatic from the cancer, but only because we rolled with the punches. We designed our treatment for that patient, and we were treating this oligoprogressive disease a little bit differently than what the textbooks might say. Sometimes even just slow progression on Tarceva treatment is best treated by adding something to Tarceva rather than stopping it, because we often see the tumors grow especially quickly if you stop the Tarceva. And everybody's situation is different in that regard.
David, can you talk a little bit about some drugs attack the lung cancer well in some parts of the body, but they may not break the brain barrier?
Right.
So, I think you've touched on it, but for the people in the room, could you explain that?
In order for a drug to work, it has to get to the tumor. And certain of the first-generation EGFR inhibitors or ALK inhibitors, for example, don't get into the brain very well. And it turns out brain metastases are extremely common in lung cancer, and especially in EGFR and ALK mutated tumors. And so if you progress in the brain, that could be treated with stereotactic radiation, or sometimes effective, as we know with certain movie or TV stars. It's effective if you, Tarceva is more effective in the brain if you give it a different way than the standard way. Again, kind of a little bit of the art of medicine there.
Right.
But fortunately, we also have new generations of drugs, and one of those companies is represented here that seems to have a drug that not only works against the tumor in your body and against the resistance mutation, but also seems to get into the brain better. And so medicine is advancing. We're developing better drugs, it seems every month, and we have to get these to people.
How do you determine, because I know there's a lot of patients in the room who have either switched therapies and weren't spot treated, for lack of a better lay term. How do you determine who qualifies for that? Like, how much is too much progression?
Yeah. It's hard to write a rule for something that's not rule-based, if you understand. I think you just have to have experience with the disease. You have to let the patient tell you, the patient is not having symptoms from it, that it's a solitary progression in one or two spots, then I would go for more local therapy. Or sometimes even if they are having symptoms, and if there's a painful spot in one place, radiation to that one place, but keeping the treatment going for the other one. So it's a hard thing to write a formula for, but it's part of the reason why it's important for patients to go to specialists who see this type of cancer every day, day in and day out. When I started in cancer in the early 1991 was my first real job, and I've been focusing on lung cancer ever since then. And I think it's important to have people who have a real feel for a particular kind of disease at least get periodic opinions from them to take advantage of their experience in the disease. In the community, some really excellent doctors out there, but they are forced, because they don't work at a big center that sees enough patients of a particular kind, they're forced to see every type of lung cancer, or every type of cancer. And leukemias are extremely different from lung cancer, and every cancer is getting more complicated, and it's impossible for one person to be an expert in everything. And so I tell people, I'm not smart enough to remember everything, but I can be a real expert in lung cancer. And at my place, we have 5 doctors medical oncologists who just do lung cancer, 5 surgeons who just do thoracic surgery. And I think that's an important thing.
Our goal here is smart patients. Our goal here is to educate all of you and get you as full of as much information as you can, so you can help educate whoever's treating you, or guide whoever's treating you in the right direction.
So I always say that patients are their own best advocates. Mm-hmm. And sometimes patients are feel a little intimidated. They say, I don't really understand this stuff. Maybe I should just do what he says. I think this affects you more than it affects the doctor, right? So it's super important that you try your best to understand what treatment's being picked for you, what the alternatives are. Make sure your doctor has considered the alternatives, and help drive that decision-making process, and not be a passive participant in it.
Do you think, because I couldn't agree with you more, and I know we tell patients all the time about seeing a specialist, and you can't expect one oncologist to know everything there possibly is to know about every cancer that's out there, right? Do you think oncology is and or will trend not only in the academic centers like it tends to, but in the community centers towards specializing?
I don't know. I don't see that trend. There are huge networks that have specialty oncologists, but it's relatively inefficient in a big system to say this doctor only sees this type of patients when maybe the next 5 patients will come in and don't fit that doctor, and then you have a little idle time with that doctor, and private healthcare systems may not like that idle time concept. But I can't speak for how people manage their practices. I personally think it's incredibly important. It is a little bit interesting because not often, but occasionally I get sent a patient that's labeled as lung cancer, and it turns out they have metastatic kidney cancer or something, and usually what I'll do is I'll transfer that patient to someone who's an expert in kidney cancer rather than trying to manage it myself. We have a CT screening program. I think I've heard someone here was in the ILCAP program. So we found 2 other kinds of cancer and 3 aortic aneurysms and all kinds of other things in the screening program at our place, and we transfer those people to the appropriate specialists.
It's just interesting, and we talk about it here, that, there's not a pregnant woman on the planet who is going to go to her, ophthalmologist to deliver her baby. But yet, no, seriously, but in cancer, you will go to, you just do. And it just, in this day and age, especially in the molecular era of oncology, it seems...
Lung cancer, 20 years ago, 25 years ago, pretty much all lung cancers were treated the same.
Exactly.
And so it was pretty simple. You treat lung cancer, you knew exactly what to give them, and actually very often it was just morphine.
Exactly.
It wasn't good treatment at all. But now it's become incredibly complicated, and not just complicated, but changes with time. And it's hard for me to keep up with what's going on in lung cancer. There's multiple new 3rd-generation inhibitors for EGFR and ALK, and new gene translocations happening all the time. We just published a new one this year that's a brand new gene mutation that a patient of mine had a 5-year remission as a consequence of. And so things change quickly, and you can't keep up with that if you're trying to do it with every cancer type.
Can you talk a little bit about, we've entered into the age of testing for molecular biology and all of those things, and I heard a story just the other day of a fellow that had lung cancer, and he also had the HER2 mutation.
Someone here had that. You had the HER2 mutation.
Okay. So
you think of that as a breast cancer problem.
Exactly.
But it is a little different. Breast cancer is generally gene amplification, whereas in lung cancer it's mutation. And we have drugs that work against HER2. Afatinib is one of them. But I was just talking about how I have an elderly lady right now with metastatic lung cancer, had a biopsy, was found to have a HER2 mutation, and we put her on a clinical trial with neratinib and an mTOR inhibitor, and I just saw her CT scan last week. She had a complete response.
Yeah.
there's no cancer visible.
Yeah.
She's never had chemotherapy. She has a great quality of life. She's 83 years old, looks like she's 60, and it's important to look for these new mutations, which many hospitals now don't. They test for EGFR and ALK.
Mm-hmm.
They don't look for the other ones.
Right.
And we heard a couple of ROS patients here and a couple of the HER2 mutation, and these are all things that I would say the vast majority of hospitals don't even test for.
Exactly.
And not even just EGFR mutations, they're not all the same. Some hospitals just test for 19 and 21.
Right.
And there are multiple other EGFR
Right.
mutations.
And exon 21.
It's exon 20.
Well, the 21, isn't it true that shows that even though that's basically associated with an EGFR mutation, that a particular drug doesn't necessarily work with that, right?
Exon 20.
But we're probably getting a little too deep here in some of this, because our goal is for you to understand that there are tests out there that will help your physician manage your cancer. But is it true that as unique as our fingerprints are to our bodies, our body print is equally as unique?
Every tumor, so if you sequence a typical lung cancer tumor, and this lady that we just found this ARAF mutation in, she had 30,000 mutations in the whole genome sequencing of her tumor, which were new mutations not present in her normal DNA. And that makes her tumor different from, I wager, every other tumor ever. It makes her tumor unique. And not only that, but every patient, every context is unique. We all don't have identical genetic backgrounds. We all handle chemotherapies differently. We all have different immune systems. Some people inherit molecular abnormalities that predispose to cancer that are just being discovered right now. And so as each individual is unique, so each tumor is unique, and tumors on top of that evolve with time, adding another level of complexity.
Mm-hmm.
So this goes to another question, kind of relating to the art and incorporating the science. We talk to patients all the time, and you're absolutely right. And the people that we talk to, it's either just EGFR and ALK, or sometimes even worse. Well, let's run EGFR first, and then wait, and then if and when that comes back negative, then we'll run ALK. And then wait, and then, right, so this goes on to the 30, 60 days until anybody's tested. But setting aside that problem all by itself, how do patients know which testing is right for them? Is it a straight lung panel? Is it a next-gen sequencing panel? If it is next-gen sequencings, which one? Or 300 better than 500, better than 600? Like, how do patients understand that?
Well, there's absolutely no reason for patients to understand that until they become a patient. And then they need to take a crash course. Because, on day -1, your biggest concern was what to make for dinner, or, the next meeting that you had. And on day +1, you suddenly have a life-threatening issue you have to deal with. And you cannot get a PhD in genetics in one day, right? So I think you need to try your best to understand through mechanisms like this, but also getting the second opinion before you start any treatment is so important. And I totally get this kind of, I can understand why hospitals do sequential testing for things, but in my opinion, I try not to make a first-line therapy decision without having all the information up front. Because for me, right now, my general policy is to see if a patient has the EGFR or ALK mutations, and if they do, then that's one type of treatment. If they don't, right now we are measuring the PD-L1 expression, for example, right up front. The very first thing when they were first diagnosed, And my preference is to go with immunotherapy if they're not EGFR or ALK mutated. And I have patients that have gotten on the immunotherapy. They've had terrific responses for metastatic lung cancer. They have absolutely no side effects, and the duration of the response goes on for a long time.
Still yet to be determined.
Still yet to be determined.
Yeah.
And these patients, I really believe, may never have chemotherapy, that they'll start on this treatment and it could be years before they need any kind of alternative treatment. And to me, that's not an approved treatment. Those right now are available in clinical trials. But to me, that's the best scenario we can work toward, and that's giving somebody an active biologic and trying to avoid chemotherapy if we can.
Well, where do clinical trials fit in the art of treating lung cancer?
Well, clinical trials are, I think, the best medicine. I mean, if you have, right now, maybe 50 years ago, clinical trials were not as well monitored as they are now. But right now, clinical trials are incredibly well reviewed, and they represent the state-of-the-art of care for cancer and are very well monitored. My wife goes around the country auditing clinical trials, making sure they do things right, and I think that's very important. But it's a way of getting access to new drugs like the Clovis drug or the immunotherapies that you wouldn't have access to
any other way
by just your doctor writing a prescription.
Right.
So a couple of these things we're talking about, whether it's the molecular genetic testing, access to clinical trials, one of the biggest struggles that patients have is gaining access to information about this, right? And we always say here, patients who are fortunate enough to find us, and I say that in the most sincere, not like puffing up our chest way, but we are able to give them that information, right? But when you look at sheer numbers of patients diagnosed globally who don't have access to us or some of the other great organizations out there who are providing this information, how as a patient are they supposed to know, like, yes, my doctor's doing the right thing, no, they're not. I mean, it's a challenge, right? You look at even basic NCCN guidelines, and you look at just in this country, the 80% of patients seen at the community level, and the trickle-down time between something being entered into those guidelines and getting down to the community, it takes too long, right? So what can patients do, patients now, to help patients moving forward? Is that clinical trials? Is it, what types of advocacy?
I think the patients in this room and the patients on the webinar are not the ones that are the ones in the biggest need of information, because they're already online. They're already researching these things. They already have friends that are cluing them into this sort of loop. So I think organizations such as yours play a huge role in getting the message out to patients. And there are others as well.
Absolutely.
But I think they really are important in helping patients to better understand the path to getting the right treatment for their tumor. There are, and this country is better off than most, but something like the last statistics I heard, 30% of lung cancer patients never get any genetic testing.
Exactly.
And something like 60% don't get EGFR and ALK testing, even once.
Right.
And missing something, even if it's a 1% frequency lesion like Ross, you can say, well, is it worth testing for that? And I know that often that's brought up among doctors.
Right.
But the way I look at it is, that Ross test costs less than 2 weeks of chemotherapy.
Yeah.
And the impact on the patient for finding that is huge.
Exactly.
And so I think there's no question that you need to do that testing. There are many countries in the world where crizotinib isn't even available.
Right.
I was just in Australia talking to a patient down there who has the ALK fusion mutation, And the national health insurance wouldn't give her crizotinib.
Mm-hmm.
So she's having to pay out of pocket.
Yeah, which is
And
insane.
fortunately she can, but there are many who can't. And so it's, we're in a period where insurance companies and governments and physicians are still learning how to treat this disease called lung cancer.
Right.
And things are changing so fast that many systems are behind.
Yeah, and I think that's another place where we come in and help patients ferret out that information to get on the right path.
How important is it, just while we're, how important is it to wait on the genetic analysis before starting treatment? I know there's a couple of people in the room that are still waiting on it. How important is that?
Well, like I said, I like to operate on complete information. In other words, I like to have all the information in front of me before I make that first decision. For example, this immunotherapy trial that we have open right now is only available to patients who've not gotten chemotherapy, so brand new patients. And so and I just had a few weeks ago a patient sent to me by his doctor, and the doctor said, well, you have lung cancer and that's bad for you, so let me give you a dose of chemotherapy before you go down to see this guy at Ohio State. And I had to tell the patient, I'm sorry, I would have put you in this trial, but I can't. You're not eligible right now. Now, every situation is different, and I have literally seen lung cancers that double in 2 weeks.
Yeah.
You see the guy 2 weeks later and he'll have tumors twice as big.
Yeah.
You really can't wait on those kinds of tumors. But the typical lung cancer may have been there for 2 or 3 years. So you do have 2 weeks or 3 weeks to really get complete information and pick the right treatment first. As with almost any type of cancer, it's the first treatment you get that's usually the most important.
Yeah.
If you pick the right treatment first, you generally have the best outcomes compared to waiting down the road. But I totally understand how patients hit with this diagnosis don't want to wait.
Exactly, yeah. Elizabeth?
Yeah, something along the lines of what you're saying about getting the genomic and genetic profiling or testing done up front. Just to kind of bring the point home is additional testing, and I don't know whether this is done routinely or not, but it's testing for chemosensitivity or other hormones testing. And I did not have the testing done when I was first diagnosed, and I was on a chemotherapy, and my second opinion oncologist, by the way, it's Dr. Gandera, suggested that I get the genomic testing done at that time. We found out that my tumor was resistant to the platinum drugs, and my initial round of chemo was carboplatin, Avastin, and Gemzar. So essentially one of the most toxic chemos in my regimen wasn't even working. And so here I went through all this toxicity, my tumor is getting more robust, and this could have been avoided because beforehand, if my physician, my oncologist at that time believed the way you do, to wait a couple weeks, find out the profile of the cancer, I would have had an optimized treatment regimen going into it instead of having someone just starting standard chemo because that was the thing to do.
That's actually a very complex question that could take an entire hour to answer by itself. But we've been talking mostly about genetic testing, identifying mutated driver oncogenes. The testing you talked about there is testing for, say, chemosensitivity. Mm-hmm. And those tests are much less robust than the genetic tests. Often they involve taking a piece of the tumor and growing it in culture or even sometimes in animals, testing the tumor, how it responds in an immunodeficient animal or in a tissue culture dish. And those tests, or they look at specific expression of proteins like ERCC1 or RRM1 that are correlated in big studies with response to chemotherapy. I think those tests are accurate in a statistical sense, but in terms of predicting for a particular patient, how they respond, one of the first clinical trials I was involved with was one that did exactly that. We took a patient's tumor, we grew it in culture, and we designed their chemotherapy based on that response in tissue culture. And we compared it in a randomized trial with patients that just got the standard therapies, and there was absolutely no difference between those two. And I think it's possible for physicians to make the wrong decision because of those tests. For example, with small cell lung cancer, absolutely, indisputably, the best treatment is a platinum etoposide combination. And I had one patient that had, they insisted on having one of these in vitro drug sensitivity tests done that said the tumor was relatively resistant to platinum, so they did not have a platinum in their initial regimen for small cell lung cancer, and they did very poorly. And they came to me, and I put him on platinum, and he had a great response. So this is one of those things where it's not formulaic. You have to know the data behind using a drug in a specific situation, and how robust these various tests are for predicting on a given patient basis how well something's going to work. An EGFR mutation will predict 95% of those patients will have some benefit from Tarceva. The type of in vitro drug sensitivity testing, it's a 55-45 kind of thing. And when I was referring to upfront testing, I'm generally, right now, I'm referring to mutational driver gene testing and PD-L1 expression. Those are the things I look at up front. Beyond that, maybe in third-line chemo, you might do some kind of in vitro drug testing like that. But I don't honestly think it's a good thing to do up front, just because it's not as robust as the other tests. And many studies, there's actually been a study where they compared 4 or 5 different chemo regimens in metastatic lung cancer, and they all did about the same. It didn't really matter which one you picked. So the differences between different chemotherapies is generally less than the difference in different targeted therapies. That if you pick the wrong targeted therapy for a patient, you'll have no benefit at all. But chemotherapies are much less black and white. Maybe one exception is pemetrexed or Alimta, which seems to really work only in adenocarcinomas and not in squamous cell carcinomas. But anyway, that was a long-winded answer to a question. It's a logical thing to do, but someone who knows the data may be a little reluctant to make major decisions based on that.
Besides just the chemosensitivity that you mentioned with that type of testing, I'm wondering about all kinds of other type of chemicals and things that are out there. One of the things that always hits me when I'm either hiking or walking up in the hills is I'll hear rattlesnakes, and so I'll go away from them. And I have this thought in the back of my head that if I did get bit, that maybe that venom would actually help the lung cancer.
Do you want to test that hypothesis?
Well, on a very personal nature, perhaps. But what I would want to know, and I've just been reading some things about Dr. Sidney Farber, and that's what got me to think about it, was, so there are thousands of chemicals out there. We have I think, the abilities now to take some of my tissue and run them against a whole host of items and find out, is there a sensitivity that would lead me to at least think that maybe this is something that could help or not?
So you're absolutely right. There may be some bug in the Amazon that when squished and injected into your veins, cures lung cancer. But I think the rattlesnake example is a really good one. that I have no doubt that it can kill cancer, but it kills people too. And so, and that's not a good compromise. So many of these things that show the ability to kill in a petri dish in an incubator, are also incredibly toxic and not tolerable by people as well. And so for a long time, that's the way we developed cancer drugs. The NCI had a program where it would send divers to scrape things off rocks in Hawaii and people to the Amazon to make extracts of various trees and things. And in fact, Taxol was discovered as an extract of the Pacific yew tree, and it's a cornerstone of lung cancer therapy. So, but every 50,000 drugs that you screen that way, one may make it, maybe less than 50,000, maybe 1 million that you test that way, one ends up having real clinical activity. The thing that's exciting about modern drugs now is we're going the other way around. We are studying what drives cancer cells, and we're designing the key to fit the lock. And I think that explains the dramatic explosion of new and really active drugs that we have today. And while it may be true that some bug in the Amazon makes something that is a good cancer drug, I think we've hit a method of finding effective drugs now that's really paying off. The immunotherapies are a great example. For years we've studied why do people get these cancers? What happens to the immune system that makes the cancer invisible to their immune system? And some very smart guys in the lab found this protein that does that. And when you put in an antibody, at least some patients, the tumor goes completely away and it stays away. And in fact, you can stop the treatment and it still stays away. And so for me right now, the most exciting thing that we can do is take advantage of all the science and technology that we have and try every which way to find effective treatments based on that science. But not to forget that sometimes serendipity drops something in your lap that you can't ignore. But those are much harder to design. It's harder to design ways to find those things, but to keep your eyes open. Oh, and actually a great example is this patient of mine just recently took a drug that hardly ever works in anybody, but it worked great in her. And we had no idea why. And it's great for her, but I would like to try to figure out why it worked in her so that we can look for other patients. And so we found that she had a new gene mutation in a gene that nobody else had ever described. And so now that kind of fortuitous observation that this drug worked in that patient and we had no idea why, with a little science we could figure out why, and now we can look for other patients with that same abnormality and use that drug in them. So that's a little analogous to the rattlesnake situation, but I think a little more scientific.
I think Andrea has some questions from online.
Yeah, no, we have.
Doug, we'll get to you.
3 questions from online. So a husband is asking a question about his wife, who is EGFR positive with L858V mutation. Tarceva did not work. She's finishing 6 months of IV chemo. Her doctor wants her to look into going back on Tarceva. How do you feel about that? Or afatinib?
If it didn't work in the original up front, it's at all. I mean, and everybody, again, this could be a situation where it just grew slowly and they decided to give up on it too early. But if it absolutely didn't work as a first-line treatment, it's really unlikely to work in the second line. And this mutation, usually it's L858R is the common mutation. That one was a little different. And there are a lot of mutations in EGFR that are just incidental mutations, non-activating mutations. And so we don't know the best drug for that. Sometimes the new drugs like the Clovis drug or the AstraZeneca drug actually may work in some of the mutations that the Tarceva doesn't work in. But I think if it absolutely didn't work and grew right through Tarceva one time, they probably you might want to consider something else, such as immunotherapy at this point, once the chemo stops working.
So I have a question for you on that point. When the targeted drug does work really well, let's say, the patient was on it for a year or so and then started to progress, when would that be a good thing after you try other treatments? When would it be a good thing to bring Tarceva back into the picture?
So that also is a complex question, and I don't think the purpose of this forum really is to microanalyze every specific case, because every case is different, and there are some unanswered questions. If Tarceva works for a while and then stops working in a convincing way, right now my preference would be to go to a third-generation drug and see if there's a T790M. But if there's not, and the MET inhibitor, INC280, doesn't work, and then we go to chemotherapy. There's a debate as to whether to keep the Tarceva going and add chemotherapy or just use chemotherapy alone. And I could talk for an hour on that. There was just a trial presented in Madrid a couple of weeks ago that randomized patients in exactly that situation, to chemotherapy with or without continuing the Tarceva. And it turns out that the people that continued the Tarceva during chemotherapy actually did a little worse than the patients that just got chemo alone. So my standard of practice, again, it varies, but if I decide to use chemotherapy, I usually give chemotherapy alone. And then it may work for a period of time. And then often I find that if the chemo quits working, I can try Tarceva again, and I'll get another response afterwards. The tumor has regained sensitivity to the Tarceva. So there's no prescription for that kind of management.
Is the art, though, of
but
treating
Tarceva sometimes works if you've had a break from Tarceva.
Yeah.
But I think it's important to note that at some point in there, I'm guessing, there was a rebiopsy, right? The patient progressed, and at some point you
should, and the standard changes.
Yeah.
I think a year or two ago, before there was the 9291 or the 1686, the standard of rebiopsy, really, there was no imperative for doing that because we weren't knowing what we were looking for. But right now, I would say there's an absolute imperative. If you have an EGFR mutation, you responded to Tarceva, and now the tumor is progressing, you need to have another biopsy because we have specific things we can do based on what we find in the second biopsy that were not in the first biopsy that have super effective treatments for them.
So how far away are you from liquid biopsies?
Well, Clovis has worked on that as well, and that was a planted question, probably.
No.
If I found, and what he's talking about is doing the genetic analysis on a blood sample instead of doing a tumor biopsy. If you're looking for something specific, such as EGFR T790M, and you detect it in the blood of a patient that's like we were talking about, EGFR mutated on Tarceva, now progressing, and now they have a T790M detectable by PCR in the blood, I personally think that that's enough evidence to try them on a third-generation inhibitor. However, if you are a brand new patient and your first genetic analysis is a blood sample and you don't have an EGFR mutation that's detected, I don't think that's good enough yet, because those tests are what's called specific but not sensitive. they can miss mutations more often than they have false positives. And so it's so important to know what's going on in the tumor. I would prefer a tumor biopsy. And people will say, oh, well, biopsies are painful and biopsies have complications. Get real, people. You're dealing with metastatic lung cancer. The biopsy is nothing compared to the lung cancer, and the information you could find from that biopsy could make a giant difference in that patient. Don't be afraid of the mosquito on the elephant's back. You know, it's the elephant you have to worry about.
Right. That's a good point.
Go ahead. Just grab your mic.
When I was biopsied, they tested for EGFR and ALK and ROS, and I went to see a lung cancer specialist, and he recommended getting the next generation sequencing. Well, it wound up there wasn't enough material to do that, and then I actually went to a second lung cancer specialist who said, well, we don't know what to do with all that information anyways, you know, and I don't know if that was to make me not feel bad that I didn't get it.
Right.
And my tumors are located, I guess, in a spot where they're not easy to biopsy, and the Tarceva is working well, and I've been told, you know, to just ride it out, because these things change anyways over time.
Right.
So do you think the next generation sequencing gives important information, or?
So another one of my rules for lung cancer is don't mess with success, right? So if something's working, don't change anything. So in that sense, if Tarceva is working and it's convincingly working, there's not a huge need for doing a biopsy right now. If you, however, at the time of progression, for sure. And that, I think the question you're asking is a question that's going to go away, because everyone should be getting next-gen sequencing from day one. Right now at our hospital, we do next-gen sequencing right up front on everybody. And so we're not looking at 300 genes, we look at about 50. And it is true that those Foundation 1 panels or next-gen panels will often come up with, you know, an STK11 mutation, and you don't really know what to do with that. That's true. But they'll come up with mutations in MET, for example, that are not a standard pathway. They'll come up with HER2 mutations. They'll come up with BRAF mutations that aren't tested for in a lot of the standard panels and do have effective treatments for them. So the answer to your question is convoluted, but one, don't mess with success if Tarceva is working. But if it stops working in a convincing way, sequencing and another biopsy is probably the right thing to do. And again, I think that this disclaimer that I didn't see probably did say that this is not medical advice. This is kind of talking in generalities, right? But and thirdly, the technology is advancing so quickly that I think it's going to be cheaper and more effective to do the latest generation of genetic testing right up front, and not do it sequentially like you're talking about.
I did a little investigating in the meantime before I found out that there wasn't enough material, and the insurance plan didn't want to pay for the next. Of course. Are you finding that they are paying?
So that's another
tough question.
Driver to, you know, I can't speak for insurance companies, but the fact is, often a given hospital will not have next-gen sequencing available in its own lab, and it has to send it out to Foundation 1, and that will cost several $1,000s. And if you've already had EGFR testing, then they won't pay for it, because what they're reimbursing is the EGFR testing and not the STK11 analysis. But the fact is, right now, this next-gen sequencer is in our hospital, and it's the way we do the analysis, and so we bill for it, and it's never been a problem. This is something that just happened. But the one fact is that NextGen does take a little longer than PCR, and this is a technical thing. So what we actually do in our hospitals, we do both PCR and NextGen. So we'll do PCR for the common mutations and get, if the result comes back in like 3 days. But we also do the NextGen, which takes about 2 weeks. But the ALK and EGFR fish, the ALK fish and EGFR mutations we do by a rapid test so that we can get the treatment to the patient without waiting for the NextGen. But who knows, 5 years from now, the NextGen, could be in a doctor's office and take 5 minutes and cost 50 cents. I don't know.
Can you just remind us what the difference is between genomic testing, like you mentioned, Foundation One, versus what NextGen is, and let's say response genetics? Can you just kind of?
Well, I have a PhD in genetics, and I don't. Those are technologic platforms. So, and I don't know how.
In other words.
No. EGFR mutations can be tested for in lots of different ways. The most primitive way is direct sequencing, and that is not very sensitive. That's where they PCR amplify a piece of the DNA, and then they sequence it. The next generation sequencing is single molecule sequencing. It's a technology where they can take a mixture of sequences and sequence it thousands and thousands of times to generate the data that you're doing, and then use computers to put it together. And it turns out this is, if done properly, more sensitive to find mutations in a wide range of places than the direct sequencing is. Places like the Foundation One test don't sequence your whole genome. They use something called exon captured, or where they fish out of the mixture of sequences the ones they're interested in, and then use NextGen to sequence them. So this is all technology that you don't really need to understand as patients, but just to understand that different tests are different, and one test can miss something that another test picks up, and that's really the job of an expert who deals with this every day. That's why I always ask, sometimes the pathology report will say EGFR wild type, but that's not good enough for me. I want to know what technique they use to look for it and to see the actual result. And by that, I'll judge whether it was an adequate positive or an adequate negative. But that's really beyond what the average person can judge, and that's why you need to get second opinions. But the technology is really amazing. These next-gen sequencing is revolutionizing our ability to detect these mutations.
If you're interested in a second opinion and you're willing to travel, what would be either the 3 top research centers in lung cancer? This is an important question.
No, it really is, because
in the United States, or researchers that you should consult with.
So I'm a cancer survivor too. I had lymphoma 15 years ago, but I was an oncologist when I was diagnosed, and so I knew exactly the doctor who was the best person to treat lymphoma. But that's because I live in that world, and it is difficult to know you're picking somebody who really has the knowledge or expertise in your disease. That's one of the biggest decisions you're going to make, because this person is going to be in the foxhole with you, so to speak, maybe for the rest of your life, and you want to have the right guy there. I use the analogy, if I get stuck on a desert island, do I want 25 people I find in a Starbucks in Manhattan, or do I want to find 25 people from the mountains of East Tennessee? I would rather have the 25 people from the mountains of East Tennessee to be stuck on a. But anyway, that's besides the point. So what I tell people, what I tell people you know, I'm the president-elect of the IASLC, but I have found that docs who are really interested in lung cancer tend to be members of this organization. If they have a specific interest in lung cancer, they tend to be members of this ISLC. And so if someone asks me if there's a doctor in Montana that I would refer to, I'll look in the ISLC directory and I will say see if there's someone in Butte that's a member, and then I know that he's willing to go to the meetings and be a member. It's more likely than not that he really cares about keeping up to date in lung cancer. When I send patients for second opinions, it tends to be to the major centers like Memorial or Dana-Farber or Moffitt or UCLA or Dave Gandera. But you may, that may be something that organizations like Bonnie's can help you with as well, because it is something that it's an important decision and it's not obvious necessarily. If you go online and research your doctor and they have no publications and then they say they specialize in 25 different types of cancer on the website, then that's a good sign that maybe that's not a lung cancer specialist.
And it's never a good idea to just choose an institution, because I personally believe it's the doctor. It's not the building. You're just as likely to get somebody that isn't as up to speed that you need them to be in an institution without doing your homework. So I think it really is the rather than the building.
So I know Andrea has she keeps trying to raise her mic, and I know Corey has a question too.
But we've got to get some online people.
Yeah, so I'm going to go to Andrea for an online.
They don't dial
Corey,
in anymore, that's all.
I'm coming right back to you after that, okay?
Okay, so there's a patient online who has been tested for 5 mutations. She's positive for KRAS. She wants to know if she should have a more extensive panel done. And is there anything in the pipeline for KRAS?
KRAS is a tough one. There are some data that certain types of inhibitors, called MEK inhibitors, may work a little better in KRAS mutations, in tumors with KRAS mutations, but the data are very, very weak, actually. And the worst thing about KRAS mutations is they are usually found in tumors that don't have anything else that's targetable. It's like KRAS is the short circuit that bypasses all of these other targeted what we call driver oncogenes. So in KRAS positive patients in specific, I think doing a zillion other genetic tests may be worthwhile, but the yield will be quite low. And what I would suggest in that case is to really try to look at the immune therapies, because they seem to work quite well in KRAS mutated patients.
So she wanted to add to that, though. She said, plus, there wasn't any sign of ALK. However, an abnormal signal pattern of 3 or more fusion signals were observed. And she wants to know what that means.
With ALK? Yeah. Well, there's, like we were talking about the different ways to do sequencing, there's also different ways to detect ALK. And you would think that DNA abnormalities are either there or they're not, but that's not the case, because I've had patients who, the standard test for ALK is FISH, which stands for fluorescence in situ hybridization. And it's a difficult test to do and difficult to interpret, and sometimes the test is wrong. And I've had patients that were FISH negative that turned out to be sequencing positive for ALK, and they respond to crizotinib, or the other ALK inhibitors. So if there's an abnormal signal with ALK that might deserve testing by an alternative way, such as immunohistochemistry or next generation sequencing. But if the KRAS signal is definitive, that's less likely to be productive. But if there's some abnormality, I think some confirmatory test is probably reasonable.
You have another? You want to ask one more, and then we'll go to Corey? Sure. What if you can't find a clinical trial? This patient's doctor says most wouldn't want him because of his brain mets.
Okay. I think they need to have a second opinion. This first-line immunotherapy trial that I'm talking about is a global trial that I actually helped write. And one of the things that I put in there specifically is that it allows brain metastases, because we're getting better and better at controlling brain metastases, and patients with brain metastases now often do quite well. And excluding those patients, I think, is wrong. And so it's not true that all trials they'll be ineligible for all trials if they have brain metastases. Some trials, yes. Some trials even look specifically at patients with brain metastases, such as with the third-generation EGFR inhibitors. They're looking in subsets of patients specifically that have brain metastases. So I think that statement is just false.
And I just have to add, some of your patients are online right now. So.
Oh, my patients?
Yes.
Well, I hope I'm saying the same thing now that I told you in clinic.
I'm sure this patient would actually call you out if you weren't saying the same thing.
I'm sure. They always do. I can trust them to do that.
Go ahead, Corey.
I think I already know the answer to this, and that's don't mess with success. But recently, Pfizer announced that they're going to join with Merck and do a clinical trial in 2015 that combines my drug, crizotinib, with one of Merck's immunotherapy drugs. And that's kind of exciting, double punch type thing. And I told my oncologist, and she said, that's probably not for you. We'll just watch and see what happens, kind of thing, with other people in it, I guess. But I'm just kind of curious your thoughts on this double punch type, way to do it, or do you see a future in a combination of immunotherapy and targeted therapy?
Yes. And as with everything else I said, there's always exceptions. I think immunotherapy and targeted therapies work by completely different mechanisms. And we find that with the targeted therapies, such as crizotinib, we're pushing the median survival curve over. People are doing well for longer, but they still all, or almost all, recur eventually. With the immunotherapies, not everybody responds. You don't get a 95% response rate, but there's a subset of patients that respond and respond for a long time and may be cured by the immunotherapy. So I think it makes terrific sense to combine targeted therapies with immunotherapies to maybe push the curve over this way and raise the tail of the curve simultaneously. And so in that specific situation, I'm actually very excited about doing the combinations. What I would not do is stop the crizotinib and go on to some experimental treatment. I think adding immunotherapy to crizotinib in your case is an exciting idea. We don't know if it's going to work, but I think in theory it's highly unlikely to be harmful. But we never know till we test it. It turns out that patients with driver mutations seem like they have a little bit lower response rate to immunotherapies than those without. But that's just early data and we don't know. And so if you'd be eligible for that, I think that's a reasonable way to go.
There was a study recently, I think out of Japan, that combined Avastin and Tarceva. What do you think about that one?
I think that's also a great idea, and I believe the data, and actually we're doing a confirmatory study here in the United States of that combination. And I actually, again, this is one of these art things, but for 10 years now, if I have before the third generation drugs were out, if I had a patient who responded well to erlotinib and then Tarceva, and then started to grow slow, the tumor started to grow slowly, what I would do is just add Avastin. Nobody else did this, but I did it. And it turned out most of the time I got a nice second response that lasted for a reasonable period of time. And nobody, my colleagues even, didn't listen to me about doing this. And I wanted them to do this in a clinical trial setting. And it wasn't, the uptake was not great. And now insurance companies are actually refusing to allow me to do it. So I've had the last couple of patients I've tried to do that with, they say, well, it's not in the NCCN guidelines, so you can't do it. But this clinical trial you're talking to had a huge improvement in progression-free survival if you start patients up front with the combination. And maybe one of my patients online is one of these patients that was on this combination. She had an absolutely complete response to Tarceva and Avastin. It's been going on for a year now, and her CT scans are read as normal, and she's on the combination. So I actually think there is something about that combination, and I'm excited about trying combinations of Avastin with some of the third-generation inhibitors too, to see how well they work. And also with immunotherapies, it turns out, immunotherapy plus Avastin, since Avastin has some immune modulating ability as well as its angiogenic ability. So you're really up to date. You must, this was just presented, not too long ago.
I told you our patients are smart.
That's why I said the people in this room really don't need me here.
They started somewhere, right? I think we're grabbing, yeah.
With regard to the PD-1, I have two questions. On the Foundation Medicine panel that my mom had at her original diagnosis, I was told by one of the scientists I spoke with at Foundation that they do test for PD-1. It's a protein, they told me, but they have some sort of test they find in there, but I'm not convinced that that's the final answer for us. So the first question would be, where do you recommend getting testing for that? And second is, has the Merck compound that was recently approved in melanoma also been listed on the compendia for lung cancer for PD-1?
Again, those are terrific questions, but the PD-1 targeted drugs are really very new. And it was just a few weeks ago that one drug was approved for melanoma. And maybe getting to your questions in reverse, I have tried in one of my patients to get that drug for a lung cancer patient, and the insurance company said no, and I'm in the process of appealing and writing letters and stuff. So it's still difficult to get it even off-label because it is quite costly. The issue with PD-1 testing is it's not like EGFR testing. It's not a DNA sequence abnormality, it's a protein expression abnormality. It turns out that tumors that express this PD-L1 protein, the PD-L1 protein acts like a force field around the tumor that keeps the immune system from getting there. And these drugs, these immunotherapy drugs, are antibodies that block PD-L1 from binding to the PD-1 receptor. And so most of the 5 or 6 companies that are making these drugs try to select patients based on whether or not that you can detect PD-L1 in the tumor. And that's about as far as the consensus goes, because every one of those companies has a different test for PD-L1. None of them use Foundation Medicine as their test, and all of them require their own company's test to determine eligibility. And in fact, some of the companies don't even look at PD-L1 expression on the tumor, they look at it on infiltrating immune cells in the tumor. But right now, these companies, since none of their products are approved, they require their test for their drug. And so if you're at an institution that has a PD-1 immunotherapy, you just have to find out which drug they're using and enroll in the screening phase of the trial and get the testing done with the test for that company. But then be aware that some companies' tests are only 10% positive, some are 70% positive. And so if you're negative by one company's PD-L1 test, you could be positive by another company's PD-L1 test and get into a different trial. Companies probably don't like me telling you this. But in addition to that, PD-L1, since it's just an inducible protein, can change with time. And you can be PD-L1 negative by a test, get chemotherapy for a year, and then get another biopsy and get that same test, and it'll be positive after a year. So the PD-L1 testing, we don't really know how that's going to shake out. And I can't imagine 5 years from now, when 5 drugs are approved, that you'll have 5 different tests for the PD-L1. We've got to figure out how to use that testing. And in fact, even patients that are PD-L1 negative respond sometimes. And so it's one of these things that just changes your probability of response, but it's not as black and white as EGFR testing. And so we're just in a period of time where we really don't know the right answer. And so we'll just have to see how things shake out.
Very new, very new.
Anybody else have any questions? Andre, do you have any more online questions? So the last question I want to ask, and then we'll move into, I don't have my watch on, so I actually asked my mom to bring out her phone so I could watch the clock.
She's not checking the Giants game.
I'm not. Although, Rick, I did have Scott give me a score.
My husband is, do we have an update score?
5-0.
5-0
Giants. So, I just want to, 6th inning? 5-0 Giants.
And it's not the Super Bowl, right?
Right, not yet. Well, it is to us.
World Series.
Every one of these games is like the Super Bowl.
That's an inside joke.
Yeah. Making fun of you for the World Series versus Super Bowl.
Oh, geez, yes.
Yeah.
If you're following Facebook, terrible. I said, he's like the Super Bowl of lung cancer, and it's like, well,
she was talking about the Giants,
the World Series.
Yeah.
Never mind.
Anyway, you can catch it on Facebook because we didn't let her take it down.
I had to detract.
Yeah. So one of the last things I just want to ask, because I think it's important, especially because we talk to a lot of patients who are dealing with this all the time, where they are unable to tolerate said therapy, whether it's Xalkori or Tarceva or something. It's managing their cancer, but the side effects are too much.
Okay, that's really, really important. And it's a mistake I see made every day by people who aren't used to giving these drugs. You should never, ever stop Tarceva, for example, because of a side effect. If you have a EGFR mutation and you take Tarceva and you have a response, but then you have a rash in your scalp or something, or diarrhea, when you have an EGFR mutation with Tarceva, you can reduce the dose of the Tarceva. The standard dose is 150 milligrams. I have many patients who are on 50 milligrams, and it works just fine, and they have no side effects. And the alternative is stopping the drug and going on to chemotherapy. Give me a break. This is not the right thing to do. And the other thing is the diarrhea. Virtually everyone who takes Tarceva has some diarrhea. And it's not a pleasant thing to talk about, but basically if your doctor knows that this is a side effect, and they darn well should if they're giving you Tarceva, they should also in the next breath say, go to the store, buy Imodium, throw away the package insert, don't read the instructions on the back of the package. Take 1 pill every time you have a loose bowel movement. I don't care if it's 20, even though the package says don't take more than 4. I don't care if you take 20 a day. Take 1 with every loose stool, and you should never stop Tarceva because of diarrhea. And these drugs are so active and so important and make such a difference in the quality of life of these patients that you should do everything you can to stay on those drugs and manage the side effects by even dose reducing, as opposed to switching to bad old chemotherapy.
And I think this is what your whole lecture is about today, the art of treating lung cancer.
Right.
It's about side effects. It's about getting on the right drug at the right time, getting the right test at the right time, the right clinical trial at the right time. But you make those decisions progressively as the cancer is moving. And, don't mess with success. It's a very unique process for everyone.
So every time you talk to your doctor, the decision that day is, what's the best thing to do for you today? Right now, given how things are going, what do we do today? It's every time you should reassess everything and try to maximize the treatment. If it's management of side effects, if it's adjusting the dose, every time you should not just say, I'm hurting or I can't stand this rash, and you should work out a solution toward those problems.
Where's Athena?
There she is.
Did you hear that, Athena? Maybe talk to your doctor about lowering your dose.
That was interesting because he said, because I'm only on 100 and I've been scared to death to go down to 50. So I've been really fighting this rash, and the doctors have given me maybe 20 different medicines, and nothing helps other than I have to take the antibiotic, sulfur antibiotic,
right.
And believe it or not, campylophenolic, and that's
everybody's
the only thing.
body reacts differently to these drugs, and so I actually, if the drug is working, again, this isn't medical advice, okay? This is talking in generalities here, but in general, going down to 50 is okay. But the other exciting thing that's out there, and I don't know, you're probably not eligible right now for it, but drugs like the Clovis drug don't target the normal EGF receptor. They target only the mutant receptor. And the reason you have rash and the reason you have diarrhea is because Tarceva also inhibits the normal skin and normal gut receptor, the epidermal growth factor receptor. But the newer drugs that are not quite approved yet have been designed to hit only the mutant receptor. And they work just as well or better than the Tarceva on the mutant receptor, but they have none of those side effects, so that they are much better tolerated. So down the road, companies like Clovis are actually starting first line with the Clovis drug compared as your first treatment for EGFR mutated disease. You do have other side effects, but generally they're just changes in blood numbers and not real side effects. But the rash in specific is not a problem.
That's really great to know. It's just like we're such individuals, because everybody I know that has this rash, a couple of people, they can use a certain drug and it'll help, and it doesn't do anything for me. But I also had colitis and Crohn's disease, so my doctor was really worried about me taking too much Tarceva because of the diarrhea, but I never got any, so it's you never know. But that was in the past.
You have the mosquito on the elephant's back here. You've got lung cancer. You need to deal with the lung cancer, and I personally wouldn't hesitate to go down to 50 or 75 on the Tarceva. You can go down to 75 from 100 and just see if it's better. One thing about the toxicity with Tarceva, like most of these oral drugs, we talk about it having less toxicity than chemotherapy, but we also heard how with chemotherapy you feel miserable, but then you feel okay after the miserableness goes away. With a drug like Tarceva or crizotinib, this is something you live with every single day of the month. And these chronic toxicities can wear on you and reduce your quality of life in a substantial way, almost to the same degree as chemotherapy can in a more temporary way.
It's not quite that bad, but it takes the majority of my time every day to make sure it doesn't get to the point.
It's every day, and it just wears on you. And so I think doctors should try very hard to reduce even these annoying side effects of these daily drugs, because they are there every single day.
Yeah, my concern is I take the sulfur drug every day, and I've taken it as long as 60 days in a row, and as soon as I get off of it, it's back on. So I'm worrying that the sulfur drug might do some damage, or the antibiotic.
Yeah, I'm a medication minimalist. I try to stop all the medicines I can on patients, but that's a valid concern. It could make, cause resistant bacteria to colonize and things, but again, it's a balance.
Well, thank you so much.
Well, you're welcome.
How far away are we from, like in the case of Athena, so she's on 100 right now, but from really determining what the optimal dose is for her? Maybe it's 62. Maybe that's the number that takes care of the rash, but still takes care of the lung cancer.
Well, right now, it's just trial and error, because we're using flat dosing with these drugs. I would give a 60-pound Asian female the same dose as a 500-pound sumo warrior, and that doesn't make any sense pharmacologically, because their blood levels are, 6-fold different. So I think we just have to titrate the drug in practice to each patient. Could you imagine a day where you would draw some blood levels and you'd say, or you'd test your body's genetics and you say, oh, you're particularly high metabolizer or something, and so you would need more or you would need less, and we could predict the dose up front? That day may come. But right now, I just think every time you go to the doctor, you have to adjust your doses. It's the same with chemotherapy, that if somebody has an infection and particularly low blood counts with chemotherapy, I'll usually adjust the next dose of chemotherapy to try to tailor the doses to the patient. But we can't always do that up front, like you're saying.
So I am going to turn this, first of all, a huge round of applause and thank you for Dr. Carbone. And we're gonna thank him again before this is all over, but I want to talk about something really important, or I want to turn the mic over, believe it or not, and let you talk about something really important. Which is don't guess test. You all saw the buttons and the T-shirts, and I hope you all grabbed them when you came in. But we'd like to tell you a little bit about what this campaign is.
You'll see more about this campaign in November, and tonight is a soft launch of the campaign called Don't Guess Test. And to Dr. Carbone's comment multiple times tonight, he likes to have all the information possible at his fingertips when he's treating a patient. And it's our belief that getting tested, molecular testing for your lung cancer, it should be mandatory. Our goal through this campaign is to have every lung cancer patient in the United States tested appropriately. Even that could be multiple times throughout their cancer journey. It's also very, very exciting for me to be able to announce that there are 15 lung cancer foundations that are joining with us in this campaign. We've partnered with all various different of these lung cancer foundations through the years, but we've never been able to agree unilaterally on a program that we could all agree on that was good for patients. And I'm very proud to say that I'm going to read their names because I know some of them are online tonight watching. It's Friends of Cancer Research, American Lung Association, Cancer Care, Caring Ambassadors Program, the Dusty Joy Foundation, Free to Breathe, Upstage Lung Cancer Foundation of America, Lung Cancer Initiative of North Carolina, Lung Cancer Circle of Hope, Roxana's Foundation, the We Wish Foundation, Uniting Against Lung Cancer, and Lung Cancer Alliance. I'm sure you're familiar with some, if not all, of these names. And we're all collectively very excited to be gathering together and joining together. And our only vested interest in this collaboration is long life for everyone with lung cancer. That's it. We have no other interest in doing this at all. So let's give all of these amazing people a little round of applause.
And there is actually a call to action and an ask here for those of you who are watching online and those of you in the room. And that's obviously to follow us on, or follow us. Yes, us, all 15 of us, 16 of us on Facebook, Twitter, and Instagram. At the Don't Guess Test, just go find it. And then you can go to the website. It's www.don'tguesstestlungcancer.com. There are buttons on there. I don't know where Ramya is, but there are buttons where you can change your Facebook profile picture to the Don't Guess Test. You can obviously wear your shirts with pride. There's a whole little media kit at the website where you can go and you can grab and pull a bunch of really fun electronic stuff. We aren't asking you for money around this. We're just asking you to spread the love. So it's just let everybody out there know that this website's available to explain. So there's FAQs on there.
Patient stories.
Patient stories, all of that. So,
about their experience with testing and their success stories and how it's worked for them.
So please, 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 please go check it out. And I know I'm gonna kind of run through my long list of thank yous and then I'm going to have to say goodbye to television, not online Ustream, but cable TV. And then I'm going to turn it over to Liz to give a little brief Don't Guess Test story. But I obviously want to thank everybody who has and continues to make this evening possible, which is I know is so important to you all and watching online, and to so many who come back and watch it later. We absolutely could not do it without all of you: Merck, Genentech, Lilly, Novartis, Bristol Myers Squibb, Celgene, and obviously Clovis. We also couldn't do it. Well, we could, I guess, but the Office Bar and Grill for donating their food every single month. It's, like I said, it's cost a night. Peninsula Television for coming out here every month and setting up their cameras and all that equipment in the back that allows us to share this experience with everybody chiming in online. We really appreciate what they're doing. The staff, the people who work here at the Lung Cancer Foundation and who help every single day to make not only this happen, but everything we're trying to do to raise money and fund research to accelerate progress here. I just want to thank all of them too.
And I don't know if we've shared what our reach is for this program, but you might want to.
Yeah, I think we've shared it in the past, but so you know how these meetings are available for the whole 2-hour segments available via our Ustream channel, but then we edit it down into 20-minute segments, and they're housed in our patient education library. And our patient education library has been viewed over 500,000 times in 143 countries. So the reach is broad. People are really, I mean, it might just be one person in Burma, but somebody in Burma is chiming in, you know. So
who has possibly asked for a second opinion? And to Dr. Carbone's point, you know, I call him a lot and ask him, but I also look at the IASLC registry, and we have found second opinions for patients in multiple countries in the world.
Yeah, multiple countries. So again, thank you all, because I know there's several of you who have been coming to this living room for the last 4 or 5 years since we've been having it, and it definitely did not start this way. It wasn't quite the production that it's turned out to be, and thank you for sharing your time here with everybody else. So with that being said, I would like also to ask everyone to give me 5 minutes of your time afterwards and stand in the center of this room so our lovely Katie can get an updated photo. If you did not sign the release and do not wish to be in the photo, you don't have to, but if you did, please get in the middle so we can grab a new photo. And then I want to close by saying yet again another huge thank you to Dr. Carbone for coming out and talking to us. He flew here. I don't know if we told you guys, but he was at a science meeting in Australia. Did we say that out loud? I don't know if we said that live. And stopped here on his way back. He and his beautiful wife on their way back to Ohio just to be here to speak to you guys. So thank you, thank you, thank you.
You're welcome.
Oh.
And thanks to Bonnie and the organization for doing this. This is so important.
Yeah, thank you. I think I have a couple of minutes left. Next month, Dr. Jonathan Goldman from UCLA is coming up to talk about sort of some of the cool things that happened in this last year, celebrations of some of the things that have happened in 2014, and then what we're calling Hope on the Horizon, some of the exciting things that Dr. Carbone was talking about with immunotherapies and some of the other things going on in trials, things to look out for. So please join us in November for Lung Cancer Awareness Month. And keep your eyes open, because we've got a lot of really amazing things planned for Lung Cancer Awareness Month in November. And I think I'm done. Do you have anything else you want to say?
No. Get tested. Don't guess, test.
Yeah. And let's take a picture and then eat pasta. There's a lot of pasta. All right. The gala. Well, I'm sorry.
The gala?
You have a mic in your hand, right?
Oh, I do.
Did everybody notice Andre's new position up here in this spot?
Right.
I didn't dress appropriate. Well, maybe.
Yeah, you did. Go Giants.
Most of you, or not most of you, but a lot of you are going to be at our gala next month, November 8th. It is our largest fundraiser, but it's also our fundraiser that has the most hope and celebration. We celebrate, this year is going to be really cool too. I mean, there's just so many great things that are happening. But November 8th, and as you guys all know, anyone who wants to come, just email me, please.
It's a great night.
Through the generosity of several donors, we are able to get patients and
we have donors who actually will support a patient and survivor to attend the gala.
Yeah,
because they know how important it is.
Yeah. So talk to Andrea if you're not already signed up. And that's it.